Welcome, Greg Lehman. You're today's guest in the small episode. So could you please give a brief introduction of yourself?
Sure. I'm a physiotherapist in Toronto, Canada. I was a chiro, so I was trained in chiropractic, whatever that is. I just don't have my license anymore. I'm a clinical educator where I go around and talk to people about all the problems we have with treating patients and try to provide some evidence and evidence-based discussions on that. I have done a little bit of research in the past, but I'm no researcher. I just like to dip my toes in it. That's it.
Yeah, that's it. So let's start there because as you said, you go around the world and teach, and that's where I met you. And I think one of the things that I noticed is that you're still seeing patients and you're very interested in the research and you seem to be well read. So you were dipping a bit into the research. I think a year ago or something like that. You made a paper with some other people changing the narrative about the SI joint.
Yeah.
If we take a paper like that, why is a paper like that still relevant in 2020?
So I thought it's actually really interesting that you bring that up now, because all that stuff that we said on that paper, I could have said in the year 2000. Yeah. But none of it was really new. Essentially, that the SI joint can be a source of nociception. It has nerves there. It can be sensitive like any other joint can be. But over the decades, there's this idea that, it gets out of place. It doesn't move appropriately. It either gets, stuck and it's not moving, or it moves too much. So that would be like a stability issue. All the research of Lehman and that group and Snyder saying like there's a problem with form and force closure. And all of these theories have been around for decades. And it's hilarious. It was just brought up yesterday on Facebook with Diane Lee. I don't know if you saw that. Adam Meekins put out a little, one of those infographics, and she took offense to it and said something like, to all those people who don't know how to treat the SI joint, which was a little bit offensive. Just because we don't agree with you doesn't mean we don't know how to help people with SI joint related pain. These are some facts about it. And it was all just word salad, right? It was the same idea that it gets stuck or it's too loose. And these are the drivers of dysfunction. And the whole point of that paper was to say, it doesn't work that way. Like it doesn't get out of place. It's not stuck. It's not unstable. Like when you really look at the research, it's not well supported. No, so that was the whole point of that. And it was just like, you had some fantastic clinician researchers writing that. I mean, Thorvald Paulsen is just excellent. His whole PhD is in the SI joint, right? So it is just such a great paper. I was happy to be part of it.
So why do you still think it's out there, the narrative that's the opposite of what you people are trying to explain and explore on and expand?
So this is the thing. I think that treatments that try to stabilize the joint or minimize its motion, or treatments that try to loosen it up and have it move differently, I think those help people. I don't doubt that people get clinical success with that. I mean, the stability approach, quote unquote, is just exercise and load, and it's often load modification, and you often address other variables that people have and get them active again and address their fears and worries and concerns. So people see clinical success, so they assume that the clinical success means that their theories behind it are validated, and they're not. but I know that these people who practice that way are still helping people. So like when you see me debate, I'm never like saying you suck as a clinician and you're not helping people. It's more of the underlying ideas, the scientific principles that underlie what people are doing, not that's questionable, not their clinical success. So that's why I think it sticks around.
Yeah, and I think it's interesting because I could have said the same as you said. Like that paper could have been written 20 years ago, and maybe it's easy for me, and maybe it's easy for you because it doesn't fit our narrative. and then we think, okay, we need to move on. And other people has this strong clinical impact that when they see it, they expect they know what's going on in there. So kind of form the basis of what you do in clinical practice. That makes it harder to let go of that idea that that is what's going on.
Yeah, exactly. It's it's a sunk cost fallacy. Like, you put a lot of time and energy into learning these motion palpation techniques and then specific interventions to address whatever you think you found.
Yeah.
And to be told, you don't need to do any of that, that can be hard on people. I was lucky. My master's was in spine biomechanics, and I actually researched manual therapy. That's what my thesis was in. And the two people that I did it with, they were doing their PhD, they were chiros, and before I went to chiro college, they're like, all this manual therapy stuff and the motion palpation, it's not doing anything that people say it's doing. So I never had those beliefs. I was lucky. I was disabused from the start.
Yeah.
And the chiro college in Canada, we taught people how to motion palpate, but it was with a wink and a nod, and everyone was taught the research saying none of these tests are really valid.
Yeah.
And I know someone's going to say, what about the Richardson study showing that examiners could agree on what the SI joint was doing? There's a paper from the early 2000s, and they'll say, oh, see, that proves that we can agree when there's faulty motion. And what I will say to people is, no, it doesn't, because all they concluded was like one group of people were moving differently, meaning like their whole spine and their pelvis was moving differently, versus another group. That's it. They could all agree that there was something different going on, but that doesn't validate the SI joint, that the SI joint was moving funny. So everyone cites, I don't know if you know, it was like 2002. And sorry, I should have drummed it up, but I'm pretty sure it's Carolyn Richardson's work.
Yeah. I think, to me, the frustration comes in when we actually have a curriculum in Denmark in our PT schools that teach people how to read a paper and to clinically appraise it critically. And then you see afterwards, they go on down that path instead of keeping what you would say like a clinical perspective that's more realistic.
Yeah.
That's me. That's where my frustration comes in, that goddamn, we taught you this, and we've learned you how to appraise the papers and the evidence out there, and then you're still going down that way without applying a critical sense to it.
No,
that's where my frustration lies.
We see that all the time, or people, and sometimes it's the researcher's fault. I was complaining about this again on Twitter, where researchers sneak in an opinion, often in the abstract or in the conclusion. Like, here's an example: that the spine has to be stable and it should be stiff for athletic performance. You'll see that written in the conclusion.
Yeah.
But that was never, a compression on a tendon should be avoided, and it's an important part of rehabilitation. So people will just say that, and it's in a paper. So then someone will quote that paper with that conclusion or that belief, but that paper never actually tested that idea.
No,
it's Trojan horsing a belief into a paper, and the paper is like I have a paper from 2,000 years ago, from the year 2000. It's a long time ago.
You're so old, Greg.
Yeah, I am. I do feel like all these debates are so old, where we were just testing the EMG in the upper and lower rectus abdominis. That was it. And we kind of concluded it didn't matter. As long as you train the rectus abdominis, you would train the upper and lower. But then we talked about not doing sit-ups because there'd be too much psoas activity or too much compression on the spine, and it could be dangerous, so don't do it. But we didn't test that. That was just a talking point in the discussion, because every researcher wants to be like relevant. So you throw this shit in there, and you're like, you should. And then now someone could cite that paper and say, oh, look, psoas activation is bad because it compresses the spine, so don't do sit-ups. Yeah. And they'll cite I've seen stuff like that where it's the person citing its fault. They shouldn't do that. It's also the researcher who sneaks in ideas and makes it look like it's evidence-based, kind of. Yeah.
So when it goes through a peer review process, it's getting cherry picked afterwards. That's where we have the problem sometimes.
It's we do it all the time. Like you'll see a paper by Irene Davis, who's a great running researcher, but she'll use the term that's a faulty movement pattern in the introduction and in the discussion, and that hasn't been established. So you keep Trojan horsing and sneaking in this idea that if the hip caves in, that's faulty, but your paper didn't look at that. But we keep using or tendon. We say, oh, the compression is bad on the tendons. We keep using it and saying these things, even though no one has ever properly tested it. And then it becomes dogma because it just keeps getting repeated.
Yeah, and I think we talked about this before, Greg. That actually leads to some of the other things I would like to discuss, is that having the strong opinions.
Oh yeah.
Yeah, based on very little data some of the time. I mean, that seems to be an issue as well, and that's a bit about the same as we're talking about now, that we seem sometimes to not be aware of our own biases, and we stick to one thing and have very strong opinions about that, which if we should be non-biased, we're not allowed to have that strong opinions.
Yeah, for sure. Yeah, I definitely agree that no strong opinions are allowed.
Yeah.
In this area, you have to have a lot of humility.
Yeah, it comes back to having that humility, but then again, maybe the strong opinions make it more interesting, and it gives you more credit to the paper. It gives you more, you sell more courses, whatever the reason behind that is. Or maybe there's really no agenda. It just kind of happens because you keep repeating it.
Yeah. The worst part is like having a strong opinion and that confidence with your patients might actually help more people.
Yeah, because you seem more confident when you're delivering the message. Yeah. I'm definitely guilty. Like, there was a period in my career where I would like explain everything with the disc model.
Yeah,
and I'm not sure I help less people
exactly
back in the days than I do now.
No,
I probably tend, despite my clinical experience now is 16 years compared to 2 years at that point, I probably feel sometimes more like tearing my hair off, because I'm more like humble, and I know less about what's going on than I thought I did back then.
Yeah, absolutely. Yeah.
So what are your strong opinions from your early career, Greg?
Again, I was pretty lucky because I was really influenced by people who debunked a lot. I haven't changed dramatically. The biggest thing I've changed would be like on the stability model of like low back pain. I would really believe like, stability was an issue with low back pain or with the shoulder, and you had to get, train the entire core. And I was advising people not to flex their spine too much or stretch. So I've made a big change there. I'm more agnostic now. Like, if you want to flex your spine, go ahead. If you want to stretch, go ahead. Like, I hated stretching in the 1990s. I went out of my way to find research saying not to stretch.
Yeah. Didn't we all?
And then in 2005, we wrote a paper with Kieran O'Sullivan. It was sort of saying stretching is useless, but because I was writing it, I decided to really read the research again. And I was like, holy crap, like I have to reconsider my opinions here. And then, so for the past 6 years, I've been this like defender of stretching. It's really funny, like this big clinical shift I've made. Not that I think stretching is fantastic.
No.
I just don't think it's as evil as people make it out to be. And then amazingly, when you look at the clinical success, like there's papers, people with kneecap pain, stretching, just a boring old stretching program isn't outperformed by a strength training program. But people are like, oh, you stretched, it's horrible. And you're like, what's the evidence for that? And you're like, oh my God, it doesn't exist. So anyways, those are my big changes. Spine stability. I still like doing stability exercises. I just don't think stability is an issue. And think like those are the two big ones.
Yeah. So if you like, you and I've worked together for a couple of years now. You've done your courses in Denmark, which we've enjoyed and been giving good feedback. But I've also heard you say that you don't think that fundamentals in recovery has changed much over the years. So you have some, I think you have a few or four, do you have four like fundamentals in your course that we kind of go over?
Yeah.
You talk about the cognitive restructuring, the specific load, the micro load, and the macro loading.
Yeah.
You kind of covered that a bit, Greg.
So it's funny, you'll see these papers about state of the art in running research or running injuries, and none of it's state of the art. Or it was the same idea 20 years ago. Like, there's specific stress on the body, you have to adapt to it. Don't do too much too soon. And then people will be like, oh, that's the acute to chronic workload ratio. I'm like, no, that's just don't do too much too soon, which has been around forever. And then you slowly build up the injured area, say the ankle, and then you do, like, with specific exercise, and then you do general activity. Like, what are you having trouble doing? Oh, running. Okay, well, let's slowly have you run again. Like, there's nothing really different there. Like I've been saying, we've been doing the same thing for probably 50 years.
Yeah.
And then if you're more advanced, that people, that's quote unquote, you consider that all of life loads and stressors can influence pain. But I would argue good coaches have done that for forever. They know that when, little Timmy is stressed out with his girlfriend, he's got to take it easy that week when he's training and he's got exams. We're not going to hammer and beat the crap out of them. Like, coaches have done that forever.
Yeah.
So like even the psychosocial aspects, that's nothing new. So we just repackage stuff. That's it.
Yeah. So if a person comes into us and you need to like kind of reconstruct their understanding, let's say, of pain.
Mm-hmm.
Yeah. You think despite what you just said, do you think that has changed how we do that over the last 10 years?
I don't think so. Again, if you read stuff from 25 years ago, we knew about central sensitization. We knew that, everything in someone's life influences pain. John Sarno has been talking about this since 1977. The biopsychosocial model has been around forever. If it's new to you, like, then you just have been out of date. Like, and you should blame your clinical instructors, right? Like,
yeah.
They probably have changed for individuals, but that's the fault of your educators.
Yeah.
Right. Like, honestly, like I wrote a paper in 1997 on central sensitization for an ergonomics course in my master's. And then that ergonomics, those professors, Rich Wells and Norman, they were talking about psychosocial factors in occupational injuries in the 90s. Like, this is not new. We know this stuff, right? It's shocking.
Yeah. So the way you apply it to your patients now is no different than it was when you were practicing 10 years ago. Or has something else changed, so make you reframe it, or do you sell it in different ways? Or
no, I'll have, like, so I've always believed that we apply load to the person or some stress and they have to adapt. That's the fundamental to me. Sometimes it's an explanation for pain, sometimes it's an exercise. And so where I've changed is, like, I used to do way more manual therapy, always as a desensitization style. Like, my thesis in 98 was we crack backs just because it helps with pain. That was it. I have no idea what's going on. It's just to desensitize. However, I have little peccadillos through the years that I've done for a while and then discarded. So I believe you applied stress to tissue to get it to adapt. I went through like 8 months of like really beating the hell out of tissue with my thumbs, thinking that was catalyzing mechanotransduction and helping healing. So I have had like questionable, episodes where I'd be like, oh, you just got to press harder on that glute med. And then I wouldn't think it released. I just thought it was, I wasn't into that stuff, but I would think, oh, that's what you need to do, is dig in really deep with your thumbs. So I've had things like that through my career, but the fundamentals, build people, calm shit down, build stuff back up. I mean, that hasn't changed.
No. So as an important part of working clinically, we often talk about goal setting and getting people on board and shared decision making and stuff like that. How do you find it when people come in in the search for your help, and you're like, they can kind of do everything, but they just want to get less pain.
Yeah.
Do you know what do you get that kind of person? They can do everything, they just want less pain.
Yeah, often. And so for them, you got to go look at, so sometimes there's probably a few different type of like options here. Sometimes you have to find out, is that pain really suffering? Are they suffering because of that and it's bothersome? And if it's not really getting in the way, like eh, this is a really hard message, but sometimes some people are going to have pain often.
Yeah.
And they might not even realize that that discomfort they're having is totally normal and almost unavoidable. When you work with enough athletes and people, you realize the successful ones aren't pain free,
No.
or they just cope well with it. And I think there's a subset of people who don't even realize that. They just think it's someone told them that it's a problem if your traps are sore sometimes. You know, if I dig into this muscle, it hurts. I'm like, yeah, that's normal. Like, we need to get that message across to a lot of people.
Yeah.
However, then there might be people where the pain actually is a problem. And if you dig in deeper, you're like, well, they aren't really doing everything they want to do, because the pain is getting in interfering with their hobbies and things they love. And you're like, well, are you really doing as, like, they might say that, but they're not. It is actually a problem. And then you want to dig in deep. I'm like, and think, okay, you know, are they doing, again, sometimes people are an endurance coper, meaning they just keep persisting into pain, and they actually might be the person who should back off for a bit.
Yeah.
Like or the opposite is, they, as soon as they have some pain, they just completely shut down. And then, so maybe they aren't really doing everything they want to do. So I would dig in deeper with patients like that.
Yeah.
Yeah.
Yeah, it's funny you mentioned the endurance copers, because I always think that when we're talking chronic low back pain or chronic pain in general, we're always talking about the fearful one and the distressed one.
Mm-hmm.
And it seems to be like, it seems to be a common theme that we need to get those people moving and get them believing in what we're doing and get experience learning to move again and stuff like that. Whereas the endurance copers, they tend like to be not spoken as loud about.
Yeah. No, I think it's a huge proportion of people where they actually need to back off. Maybe they need to look at other things in their life that could be sensitizing. They're not, sleeping enough, and they're stressed. Like it's sort of that idea. They have a lot going.
Yeah.
That could be sensitizing them. And of course, I say this with a grain of salt. I know how difficult and actually impossible it is to figure out exactly what's driving someone's sensitivity, but we can look at, uh, like the big picture and think, well, there's a number of things we could probably do.
Yeah, exactly. There's most likely there's more than one option.
Yeah, that's what's great.
Yeah, that's I think that's what I've learned over the years, that there's a lot of options sometimes. But then again, that leads me a bit back to guideline-based physiotherapy or guideline-based rehab, because
Yeah.
that's sometimes interpreted as that you can just do whatever. I mean, what do you take on that? Because if you could just do whatever, why aren't people just doing whatever?
You can just do whatever, but this is what I would guess. And this is why we see so many different people helping so many different people, is that sometimes some intervention just clicks for someone for whatever reason. So many different factors, the person delivering it, where they are in their life, it just happens to resonate. That's what I think. That's why, like, you're always amazed, your patient will tell you a story about how they were helped in the past, and you hear the treatment, you're like, that is just a bunch of bullshit. And the person just loved what happened and they were cured. And you're like, oh my God. We can't say anything. And to me, that used to frustrate me. And now I just think, oh no, that's just the wonderful world of complexity. That's how pain works.
Yeah.
That lots of things can help people. And they will at different times for that person.
But do you think we can kind of oversell the positive message? I mean, a person comes into you and they're suffering with pain, and we want to stay positive, and we're saying, well, lots of things could work. Well, it's not really that bad. It's going to be good anyway. Give it 6 to 8 weeks. It's going to be better. And you can actually do whatever you want. Because from my perspective, I think that sometimes we're overselling that positive attitude. And then we're kind of almost neglecting that the patient has just told us that they're suffering. You get my point?
I do. And to be honest, I do try to tailor my interventions. Like I like to try to guess like, okay, what is it about this person that needs to change? Right? What do they need more of? What do they need less of? So I still think like there's a tailoring possibility there, that it doesn't mean just you can just do whatever and people will get better. I still believe in tailoring sometimes.
Yeah.
But the thing is, I think that what I mean where you have lots of options is you can tailor things a number of different ways. That's the idea. Like if you think, okay, I think we need to desensitize somehow. And for me, it would be like the way I like to desensitize would be, what are you missing? What are the things you want to do? Can we start doing that again? Just a little bit of walking, a little bit of hiking, more time with your grandkids, whatever it happens to be, nice explanations of pain that there's hope. Someone else might do a desensitizing approach where it's all about breathing and relaxation and mindfulness or acceptance. You know what I mean? That's like, if we could parse down and figure out what are the mediators of recovery, and what is it that has to change, then we can kind of choose what are the different ways to achieve that. That's what I mean about there's lots of options.
Yeah.
Or someone else might say, you know what, you got to like join CrossFit. You got to challenge yourself. And and actually that ends up calming them down because they do all these things that they never thought they could do. And it's, it takes the threat away from their low back pain.
Yeah.
And someone might say, oh no, you built up their glutes. I'm like, no, you just gave them hope again and they got active, and activity was the most important thing. You could have done rock climbing.
Yeah. I think there's some point to that. I've just experienced that, and that could be, then I might draw some conclusions that I actually can't, but I just think sometimes we're overselling it based on what the patients are telling us, that, well, I saw this person and he told me I could kind of do whatever, and my doctor also said it would be better in 6 to 8 weeks, but the pain hasn't been gone yet. So that's where I'm more into what you're saying. We're trying to tailor it to the individual.
Mm-hmm.
Because I think we need to be honest that, we know it's getting better within 6 to 8 weeks with most musculoskeletal things, but we also know that for some people, a drop in a 2-point in a numeric rating scale, that's really not that much of a difference in their pain.
Yeah, no, I agree. Like the 2-point that's the 1.5 that exercise tends to give.
Yeah.
So I think we do need to look at research and look at this spread that we see. So we'll say something's clinically successful, on average it is, but then there's like 40% of people who kind of dropped 1 point, which is nothing. That's just, you're in a study. So you're like, oh, I guess it's a 4 out of 10 instead of 5.
Yeah.
You know what I mean? Like, I don't know. We should acknowledge, again, that's just acknowledging that not everything, not one intervention won't help everyone. And this is why I don't shit on manual therapy, even though I don't really do it anymore. Like with knee away or low back pain, I'm like, not everyone wants to exercise. They're comfortable spending the money to come in, for some once a week, or to start 2 times a week and then every few weeks. And like that'll resonate with people. Now that will help a subset of people.
Yeah.
I just have difficulty, like, I think it's stupid if you say, oh, you're like helping the cartilage heal or realigning a joint or something. But if you can say, no, it's a desensitizer, this helps with pain, and then the person does more in their life and they're happy again, great.
Yeah. I think earlier in my career, I've probably been guilty of saying I wanted to see people as little as possible. And I know that's a very nice message to give. And I still don't want to see people that much. But I also think over the years, I kind of got to recognize that some people, they need more they need to use us more as a motivator
Yeah.
or a coach or whatever you call it, and that we actually, as in the position as clinicians, we should accept that part, because it's like part of that world. And I know it might be a bit unpopular with some people, but that's just what I resonated over, like over the last 3 to 5 years, that it's I might have to be less rigid than I actually wanted to be, just to get good outcomes.
I completely agree. We're on the same path. I've definitely been guilty of under treating people. And I mean, psychologists don't do it. They regularly see people. If someone's dealing with anxiety or depression, they're not always healed, you know, and they'll just see them. And I love the idea of like of being a resource for people. And so I always suggest to younger clinicians like who are like us, like it's okay to see someone 3 more times than you think. You still provide value. You can give advice on exercise. You can explain more about pain. You can there are things that you can provide.
Yeah. Also because I think it's a process, and the the premises that just because, at least to what I'm doing, my exercise is definitely my bias.
Mm-hmm.
So just because we would provide some people with an exercise, it could still be a process in that.
Yeah.
And the buy-in could be a process. And so I think it's an important, maybe not spoken of message, that we actually sometimes stick with the patient, or they stick with us, like for another 1 or 2 visits.
Mm-hmm. No, completely agree.
Yeah. So what do you think we should do more of as clinicians?
Oh
Think
shit.
what should we promote more of, Greg, if you like? I know you can't decide, you can't rule the world. I got the Thanos glove and stuff like that, but
I mean, 2 things. One is I think we need more acceptance that some pain, like often, is normal, right? Like I have aches and pains everywhere that will change. I'll have bouts of back pain, and that's good. And then I have heel pain, you know, Achilles pain, and I just work around it. And again, many people that I know who are in their 40s or whatever, and are still like active, that's just what you do. I think that's such a huge message. I'm trying to belittle people's pain, like, but it's weird. It's accepting that some pain is normal. And I swear for a subset of people, that's de-threatening. And it's like, just knowing that it's okay, and that I'm safe makes me feel better, you know. So that's always my huge message for people. And the other one is like, I think we need to sell the idea that graded activity, or like resuming meaningful activity, is a real treatment approach. You're not just telling people, oh, do whatever you want. You can actually dose it. Like maybe it helps for people, like we're always prescribing exercises, you know, 3 sets of 5. Well, you can do that with meaningful stuff, like be someone's coach and help them come up with a plan, you know, and then coach them through life activities like that. That's the intervention. It's not always about doing quad extensions for knee pain. It's about, well, let's get you hiking and walking and running or whatever it is you want to do again, and gardening and squatting.
yeah.
That the meaningful activity is the exercise.
Yeah.
But I swear we look down on that. That's not real treatment. That's not physio. I'm like, no, it can be. You can sell it. You should be positive about it.
Yeah. And then again, if you needed people to accept that some pain occasionally, or maybe all the time, was normal, and it would be beneficial for them to have some kind of acceptance over it. We just have it on the other side again, that what I would say is the more negative impact of that is that we're selling like the healthy lifestyle, the good looking, and the pain relief. I mean, that's just, it's just a difficult message to compete with.
Yeah. Yeah, no, exactly. It is a shitty message when you're like telling people that they shouldn't have pain or they shouldn't be tender on all these body parts. Like that is, I think you're setting people up to fail.
Yeah.
When you do that. That's what Instagram is.
Yeah, exactly.
Both like body composition and like function and performance wise.
Yeah. That's really. I think that's a place you don't want to go if you have pain.
Yeah.
If you were to give younger clinicians or younger researchers a few advice based on your own experience over the years, Greg, what would that be?
Well, research advice is, I'm not the best person to talk about
Okay,
that, but
don't do that one then. But
yeah.
I just mean you've
Researchers have it tough. They have to get funding. They have to get tenure. They have to do things they don't want to do. It's such a shitty game. I don't. It's hard. It's a bullshit system. They got it publications and and so it's shitty. So don't feel, if you're a researcher, don't feel guilty about just publishing crap to pad your CV, because maybe you can publish some gold in there as well. It sucks to be a researcher. I don't. It's horrible. Anyways, for clinicians, it would be don't listen to the assholes online who say that they help everyone and that they have all the secrets. Like, none of us do. We all suck at some point. There's so many people that we don't help. All you're hearing online is people's success stories, and we all have success stories. Like, who cares? You treated the strongest person in the world. Big frickin' deal. Like, and you help that person. That doesn't prove anything. You have to listen to people's failures as well. And they're not failures. They shouldn't even say that. It's just normal.
No.
That's what happens when you're a clinician.
Yeah,
you won't help everyone, and don't beat yourself up.
No, yeah, because I think that's very important to remember, that we don't have everybody, and none of us helps everybody.
Yeah.
We often have that discussion. I think it's become more mature the older we get. So that's one of the benefits by getting older.
Yeah, there's so much goddamn arrogance that just belittles people.
Yeah.
Where we tell people, if you call it non-specific low back pain, then you're a non-specific clinician, or you're not a master clinician. Like, it's so insulting to people, right? Like, that no one has the answers. Like, people just because you're yelling something and you say it all the time doesn't mean you're right.
No, that and then it goes back to the
Give yourself a break.
Yeah.
Exactly.
Yeah. Greg, thanks for sharing your thoughts and ideas on my initiative. So I don't hope I woke you up too early. Where'd the cat go, by the way?
Oh, I don't know. Probably in the ceiling.
It got adopted already.
Hope so. Too many cats.
Well, thanks for participating, Greg, and cheers.
Yeah, thank you. Bye, everybody.